That was the first medication. So belimumab is one of the new medications we have to add on to the standard of care for lupus nephritis and helps a bit get better outcomes. Around the same time, another medication was being studied with the same purpose. And it was approved, was the first actually medication to be approved by the FDA for the treatment of lupus nephritis. And this is called voclosporin. Voclosporin is a medication that is in the same family as a medication you may know because Dr. Fernandez uses it a lot for the skin, that is tacrolimus. Have you ever been on tacrolimus skin ointment, or sometimes they use it for the eye? But it's another immunosuppressant medication. This type of medications are used a lot in kidney transplantation and in transplantation, and they were studied in lupus nephritis, mainly in China, and they saw that adding them on to the standard of care, again, being mycophenolate or cyclophosphamide, patients did better, mainly in terms of faster reduction of urine protein. So they started to study. These are all these studies that have been done with voclosporin over the past few years. We're going to talk about this, and don't get confused with this. I just have it for my own, but this is the study that brought the drug into approval. This is the Aurora 1 study that basically studied the addition of voclosporin, this new medication, to a standard of care. In this specific study, the only standard of care drug that was used was mycophenolate, so was not studied with cyclophosphamide. But they basically compare patients with lupus nephritis treated as usual, with mycophenolate and prednisone versus that plus the addition of this medicine to see if we could rise the chances of achieving that remission that is so low up to now, right? Like 40% or so. So, and just for you to focus at the results that are over here, this was it was a 1-year study, the initial one. On your left side, what says voclosporin says how many patients actually reached that complete remission at the end of the study when we added voclosporin versus the ones that did not add it on. And you see that it was a difference like of 18%. So 18% more chances to get into that point at 1 year with the addition of voclosporin than without the addition of voclosporin. And the other important point is at the bottom, that is how long it took patients to reach that goal of less than 0.5 grams of protein. That is what we think is the best for your kidney. It was half the time. That's in days, 169 versus 372. So it's a drug that when we add it on, as very fast makes the urine protein come down. Sometimes patients with lupus kidney disease are really swollen, are leaking a lot of protein, and we got to get this down fast because the other treatment may take months more to get you there. So this is amazing that we have in the armamentum now to help those patients to achieve their remission faster, okay? The comparison of side effects was similar in the two groups. That was the same for the prior study. Yeah. One important thing that I haven't mentioned, but is very important for both studies, is that these two studies, the belimumab study and the voclosporin study, they also have as an objective to see if they could reduce the amount of prednisone used fast without affecting the outcomes. And more recently, these two studies show that we can do a very fast prednisone taper and start with lower doses of prednisone and achieve as good of a result. So before, we used to start patients on 1 milligram per kilogram of prednisone per day, mainly if you're 80 kilos, like 80 milligrams or 60 milligrams. Now we start them at half that dose, so sometimes even lower than that. So that reduces a lot the side effects associated with prednisone, weight gain and like striae and high blood pressure and depression that we used to see before, because now we can do much faster taper. When we add these drugs, allows us to taper prednisone much faster. Okay, so that's another very important advancement in the management of lupus nephritis. This is nothing for you to look to, but basically this group of researchers, a group of those patients, 200 patients of that group, they continue the treatment, the two different groups, voclosporin plus mycophenolate and voclosporin and mycophenolate alone for 2 extra years. So there's 3 years data. And at 3 years, we still see benefits of the addition, and we don't see more side effects. One of the concerns using these medicines like voclosporin is that tacrolimus, that is an old generation of this medication, over many years causes scar in the kidney. We see that in kidney transplantation or other heart organ transplantations. After years of use of this, the kidney gets harmed. They think this drug is a bit more target and has less chances to cause that. So, but they were looking into how was the kidney function after 3 years on patients that were maintained on this drug. And actually, oh, this one is the slides, it moved. Actually, it was actually better at 3 years, just slightly better, in the group that took voclosporin, but no difference, so no worse outcomes. And this slide is a biopsy slide. So a year and a half after starting the treatment, they got a kidney biopsy on some of the patients that got voclosporin to see if there was more fibrosis or not, and there was not more. So at least at 1 year and a half, we have up to 3 years of data that we can use this drug safely and get better outcomes. And we get up to that point. In lupus, we have a lot of that. In kidney disease, is that we know how to start things and we don't know how to taper them. But that's a different story. So the new guidelines for the management of kidney disease that just got published this year now include belimumab plus mycophenolate or low-dose cyclophosphamide, or mycophenolate plus a calcineurin inhibitor like voclosporin, as part of the guidelines, was not there back in 2021, okay? I don't want to drive you. These are the new guidelines. There's all the details. And as we discussed before, and that's just kind of, I'm gonna try to finish, it's not only important to achieve that remission, that is the first control of the inflammation that we do with these very hardcore drugs, but we gotta keep it under control because the disease may flare in up to 60% of patients. So we have to have a maintenance therapy. Because if we don't do that maintenance and we slowly taper stuff when we think is right, the right time to do it, you have a flare. And the line in blue is the patient that was treated once and did not flare. No, that's a normal patient with, that didn't flare. And the line in red is one flare, and the line in the lower one is multiple flares. So if you get treated appropriately, your kidney function will drop much slower. But if you don't and you flare, you will lose your kidney function much faster. So it's very important to prevent those flares. One thing with belimumab is that it was shown in that study that I talked to you before that decreases the risk of flare too. So that has added benefit. I'm not going to dig too much into the maintenance, but just for you to know, we usually do maintenance with either mycophenolate or azathioprine. Mycophenolate is, for most patients, the drug of choice, but for Caucasian, azathioprine is a good drug. And the maintenance has, the total treatment of lupus nephritis nowadays is recommended to be up to 5 years. So it's a lot to process when you get diagnosed with this, you know, because it's not that you're walking into this and it's like, well, 1 month and I'm done. No, it's like, I gotta be on this treatment. If I want to do it right, for 3 to 5 years, most recently 5 years pushing, because we really want to taper the drugs very slowly so you don't flare. And once you're on it, sometimes patients are left only on Plaquenil as the maintenance eventually, but you do have to continue throughout your entire life getting your urine check and your blood work check to make sure there's no flare and you catch it soon, okay? And then you get treated as needed. Sometimes patients don't respond, as I told you. 60% of patients or 50% of patients would not respond to these therapies that are the standard of care. And then we start to try different things. There's nothing like fully proven. We have other medications that we can try. Rituximab is a very common medication that we use for what we call refractory lupus nephritis, when the patient doesn't respond to anything. And then we start to combine things sometimes, and every person is a world. Every person responds differently. Every person has different side effects. So the treatment is patient-tailored, okay? We have the guidelines, and from there, we take it to the patient and see how the patient does with that treatment. And we adjust based on the response. That's very important. That's why it's so important to keep going to your doctor and get checked, because if you forget about it and you say, maybe things are not going in the right direction, and you still could lose your kidney function. So I'm not going to talk too much. I think like Emily is going to be talking about this, but we have some other medications that are being studied that have shown like good outcomes in kidney disease. Obinutuzumab is one of them. It's a stronger version of rituximab and has had good promising results in lupus nephritis, mainly when it doesn't respond to therapy. And I think Emily is going to be talking a lot about this CAR T therapy, so I'm not going to dig into that. And then just for you to take away, so lupus in the kidney is the most common serious complication of lupus, okay? Despite the standard of care, the outcomes are still not great. If we delay treatment, the outcomes are worse. Protein in the urine is the best marker of disease progression, so we gotta monitor for that, okay? There's new treatments, mainly voclosporin and belimumab, and there's many options coming. So there's a lot of things coming down the pipe that I think will help us achieve better, even better outcomes. I want to finish with that. I know I speak fast. I know I have an accent. So if anyone needs me to talk to you separately later, I have no problem. I'll give my email to anyone and you guys can reach out. Thank you. I'll take any questions.
Does anyone have any questions for Dr. Provenzano? Okay. I'm going to I do it every time. I'm going to take the microphone and bring it right back so our friends at home can hear.
How do you feel about Farxiga being used as a preventative?
How do you feel about Farxiga being used as a preventative?
So Farxiga is a type of medication for the people that don't know that it's called SGLT2 inhibitors. They're drugs that have been invented initially for the management of diabetes, because what they do is they block the reabsorption of sugar at the kidney level. So you just pee sugar. This was a study for diabetes, and a same thing that happened with belimumab. Sometimes we start to see outcomes that we were not even looking into that. And they start to see that patients with diabetes and kidney disease did better on this drug than the ones that didn't take it. It also helped a lot the heart. So from those diabetes trials, a lot of trials came into kidney disease and heart disease to further study these kind of medications in non-diabetic patients. And we have data that these medications are very good for patients with proteinuric kidney disease, non-diabetic. We use it usually not as prevention, but as one of the medications that we use for renal protection. So I have several of my patients with lupus that have residual protein, because sometimes what happens is that the protein in the urine could be from inflammation or could be from chronic already scar, because sometimes we got a bit late, and some patients always have protein that we cannot treat with prednisone or Cellcept, so those are patients that will benefit from something like Farxiga.
Any other questions? Okay.
Hi, I have a two-part question. I was diagnosed with lupus 25 years ago, and I don't have kidney issues, but each year something has went on. I have Sjogren's syndrome. Does that in any realm lead to kidney issues?
So does Sjogren's impact the kidney?
Thank you for the question. Good question. Most rheumatological autoimmune diseases can affect the kidney, much less common than lupus. Sjogren's sometimes is associated with what we call interstitial nephritis, like inflammation of the tissue around the filters and stuff. Occasionally can cause other forms of glomerular disease. I think that any person with an autoimmune disease has to have his urine and kidney function checked every so often. And once we find an abnormality, usually we decide on the biopsy, and from there we take it, and then we may find something that is more suspicious of Sjogren's, like this interstitial inflammation, versus something more suspicious of lupus. There's different markers, but yes, it could. Not as commonly, but it could.
Any other questions? Oh, one more. Okay. You guys want me to get a workout today, and don't you?
Yes, hello.
Hi.
I've been taking, well, I just keep saying CellCep because the microphenate.
CellCep is perfect.
I've been taking it for years, and at first, like you said, she started me off low. Then I was up to like 3,000 milligrams per day. But then after I got COVID, they took 1,000, milligrams away. Could you explain why that? And they said that my function is getting better.
Good. Yeah.
I'm not sure I can repeat that one,
I got you.
but I think you have that, Dr. Provenzano.
Thank you. Good questions. So I didn't dig into all these details, but the treatment of kidney disease, the treatment of any lupus manifestation involves an induction phase. That is when we want to control the inflammation. If we can eliminate it, sometimes we can't completely, but we try to bring it to a low level. And once we get there, we start our maintenance phase. Usually, when you have active lupus nephritis of the inflammatory kind, we induce with doses of CellCep up to 3 grams a day, as tolerated. Some patients can get that high. And we try to maintain those doses for at least 6 months, sometimes even longer if we didn't get to where we want to get. Once we get to our remission, that is usually bringing the kidney function back to close to baseline, urine protein less than 0.7, 0.5, then we start to taper slowly. I'm not sure when, but when you hit COVID, maybe you were already in remission and you were on time to start tapering your CellCep. But it's true that COVID is a very serious disease, and if we don't, we don't want you to die from the virus, right? So assuming, and even if you're not flaring like crazy, losing your kidney function, we many times drop down those doses to allow your immune system to fight the infection. And then, if we have to, we bring them back up. And if we don't, maybe you were already in remission, you didn't need to come back up. And I would assume if your kidneys remain stable, that was the case. And probably, depending on how many months you are on the south, and maybe in 6 more months, if you're still in remission, your doctor may consider to taper it a bit farther and eventually slowly taper it up to the 5 years course. Okay. Yeah, you may, we can chat later. But maybe eventually you may have to taper. One thing to say is that, kidney is one manifestation of lupus. Sometimes I think that I'm ready to taper from a kidney standpoint, but there's a skin manifestation or a heart manifestation or some other manifestation that does not allow me to do that. So it's a teamwork. That's super important. That's why we're 4 here, and actually there should be many more. Decisions are not made by just me. I call my rheumatologist, I call my dermatologist, I call my cardiologist, whoever active disease, and then we decide together, is it a good time or not to taper? Okay, thank you.
Great. Thank you, Dr. Provenzano. We appreciate it. Okay, so I think, Alex, do you want to come up here? I am going to go ahead and introduce our next speaker today, who is Dr. Samuel Kelly. Dr. Samuel Kelly completed medical school at the University of Pennsylvania, where he also received a dual degree in biomedical ethics. He pursued an internal medicine residency at UT Southwestern and is now completing a general cardiology fellowship at Cleveland Clinic. Dr. Kelly's professional focus surrounds the care of complex heart disease and heart failure, including the overlap between cardiovascular disease and autoimmune disorders. Dr. Kelly will speak today about the cardiology and rheumatology connection. Please welcome Dr. Kelly.
Thank you all for joining us. Hey, everybody. Really appreciate y'all being here. Thank you, Dr. Provenzano, for that introduction. As she said, I agree completely. This is a team sport. And in fact, my part of that team will be fairly limited because, as you'll find out soon, we know very little about lupus in the heart, except for the fact that we need to know more. So these folks will be making the main decisions about your care, but I'll be here to try to sort of guide us as to bigger picture stuff. Whoops, and we went all the way to the end. Let's try that again. So I want to focus on the idea of heart health here because a lot of this is going to sound scary. Unfortunately, our organ is the one that often gives out at the end of life. So there's going to be some stuff in here that's not fun. But the point of all this is to say, here's how you prevent this. Here's how you stay healthy. It's not to be scary. I have no disclosures, no conflicts of interest. I'm not trying to sell anything. I mention that because I'm really glad you all are here. Patients with complex diseases and patients with debilitating diseases are at the prey of people who would like to sell them things and sell them misinformation. And it's important that you receive your information from places like this where we're working responsibly with industry partners, working in a way that really is for your care. So, be cautious out there. There are people who will try to sell you a lot of bogus junk. To that end, I'm going to try to keep this as simple as we can and say, what is a heart healthy lifestyle? That's your number one focus. The biggest thing is risk factors for heart health for everyone else are the same as the risk factors for all of you. So everything you think is bad for your heart probably is. Everything you think is good for your heart probably is. It'll get more complicated from there, but that's the big point. Now, there are a couple parts within lupus specifically, and there is no way on earth I could possibly cover them all. As we've established, lupus is an extraordinarily complicated disease, and its manifestations in the heart are also complicated. So I think where I'm going to try to have y'all focus is two concepts, which are inflammation and clotting. Those are two things that are kind of unique to lupus in the way it affects the heart. It's a little more involved than that, but if you take away two things for lupus specifically, try to think about those. And I'd like you to have some thoughts on what we can do to keep your risk as low as we can, and then when do you really need an expert? Because some of you will, and many of you won't. So this is, as with many of Dr. Provenzano's slides here, basically to say, wow, this stuff is complicated and we're barely understanding it. So I'm sure some of you all understand greater than I do the spectrum from autoimmune to autoinflammatory, but it is wide and varied, and I won't pretend that I know exactly where each of your diseases falls within this. But we do know and have known for a while that it involved the heart. This goes back as far as Dr. Charcot goes back to, I believe, 1881. He identified patients with inflammatory arthritis and heart disease. So basically, as soon as we knew how to examine hearts and joints, we knew there was something going on there. We have not even today really quantified that. We are just starting to incorporate autoimmune disease into our risk calculators for heart disease. So I figure ask the internet first. If it's complicated, what does the internet say? So when you ask ChatGPT, it says you can get pericarditis, myocarditis, coronary artery disease, valvular heart disease. You can also get arrhythmias. You can also get pulmonary hypertension. You can also get cardiomyopathy. So that's true. Everything that said is true. But it's not super helpful. That doesn't do a lot for you all. And for example, cardiomyopathy literally just means heart muscle problem. So most of these terms are just not useful for everyday life. So I'm going to try to focus for y'all on what do you need to pay attention to? What do you feel? And by the way, just a FYI, don't ask Dr. Google anything about lupus. You'll get very different answers no matter what you put in. Of all the diseases, this is not the one. So let's try to do it in simplified terms. What is cardiovascular disease in lupus? Big picture, like I said, same risk as everyone else. Inflammation and clotting. So what does that mean? Okay, so it's a little oversimplified, to be honest. Everybody's risk. That's coronary artery disease. That is hypertension. That is kidney disease. That is peripheral artery disease. Smoking, unique in this context for Raynaud's. We'll talk a little bit about that. But all the big stuff you think is bad for your heart is important to you all as well. Inflammation. So I'm lumping those in what's often called serositis is the group term, but the relevant ones you'll hear a lot in lupus are pericarditis and myocarditis. I've underlined the itis there because nobody told me until med school, itis just means inflammation. So anything that's an itis is an inflammation. Pericarditis is the inflammation of the area around the heart. Myocarditis is of the muscle of the heart. But either way, it's inflammation around the heart in the chest, and it is uniquely common in lupus. And then clotting as a broader concept can include a lot of things around the heart, but the real part I want to focus on are valve diseases, and then what we call embolic phenomena, so strokes, clots that can go to other parts of the body, clots that can go to the lungs. It's another important issue for folks with lupus. So the big thing, global risk. So everybody has these problems, but I'm sorry to say everybody with lupus has the same problems a little bit worse. Basically, no matter what it is, if there is a heart problem, you are at higher risk of it if you have lupus. It's almost across the board a double risk. And I saw a why though in the audience, and the short answer is we don't know. Inflammation. I will be happy to speak to what the underlying science is. I will tell you up front that I am not a basic science researcher, and I barely understand it when I try to grapple it. My best understanding is that we don't fully know, but we do know that inflammation is a player in all sorts of heart disease. Atherosclerosis, coronary artery disease is fundamentally an inflammatory process, and we are just figuring out how that works. So that's the number one thing to know. No matter who you are, all comers, cardiovascular disease is the number one killer of adults in the US. And that includes adults with lupus. It is similarly true there, and it is the cause of death in about a third of lupus patients, and about 2/3 of lupus patients will have some degree of cardiovascular disease in their lifetime. Now, most adults will have, or about half of adults will have some, but it's higher in lupus patients. And just, I didn't realize this, just to give a sense of spectrum, that is, after that is cancer, then infection, which I think of as a very big concern in my patients on immunosuppressant. That's actually only 10% mortality versus 30-some for cardiovascular. And then kidney disease, which, as we said, the most common manifestation. Well, we can actually replace the function of the kidneys much better than we can replace the function of the heart. So even that one, very, very important though it may be, doesn't actually end up taking folks out as often. So that's why I try to emphasize for folks that you really have to, as it's unfortunate to do, but you have to take all the stuff that everybody else has to do on top of your lupus care. You kind of have to also do that stuff. And I wish I had an easier message than that, but that is the nature of it, is you do have to do all the usual stuff to keep your health appropriate. The most important part of that is young folks have disproportionately high risk. So an 80-year-old with lupus is not that much more likely to have a heart attack than an 80-year-old without lupus. But a 25-year-old with lupus could have a heart attack in a way that a 25-year-old without lupus could, but it's much rarer. So the relevant part of that is young folks with lupus, you are never too young to have X, Y, or Z. Something where somebody says, no, you don't have that because you're 25. That doesn't apply if you have lupus. You probably still don't get me wrong. You probably still are not having a heart attack at 25, but all those rules sort of go out the window. You are allowed to be checked for anything at any age. And so that is, so don't disregard symptoms. If you don't feel well, you got to get it checked out. And then to be proactive about it, because all the stuff that everybody else has to deal with when they're 50, like so many things in lupus, y'all have to pay attention to a little bit sooner, and that's unfortunate and it's not fair. But the reality is that it is how you keep your heart healthier longer, as you start these things earlier. So specifically, what are those things? We talked about coronary artery disease. That's the classic blockages in the heart blood flow that causes heart attacks. That is more common in lupus as it is in other diseases. But also, there's this very confusing spectrum of things we call MINOCA, which is myocardial infarction with no obstructive coronary artery disease. So what that means is it looks to all the world like you came in with a heart attack. Everything looked like you had a heart attack. We took you to the cath lab. We looked for a blocked artery, and we didn't find one. And we can't figure out why you look like you had a heart attack. And that falls into this category of a whole mess of other things which aren't worth your going into, but are worth you knowing that you all are at risk of that with lupus in a way that it looks for all the world like a heart attack. You might come in, say, it looks like you had a heart attack. They might tell you you didn't have a heart attack, and that can be true. That is, there are very unique and weird things. So it is important to get it checked out, but it's also important to recognize that it can feel super real and turn out to not be anything. Hypertension of the kidneys, obviously, this was just covered to a great degree, but very briefly, I'll say, steroids, obviously, they increase your blood pressure, your weight, they increase your cholesterol. Evolvingly seen, very prevalent. I oversimplified to say around half of folks, but basically, cardiorenal syndrome is this idea that if the heart gives out, the kidneys will give out. If the kidneys give out, the heart will give out. That is almost universally true. Basically, nobody with one of those organs failing has the other organ working. They have to work really well together. So protecting your kidneys is fundamentally part of protecting the heart. That less than 5% of folks dying from kidney disease, well, that's because when their kidneys go, we can protect those, but then their heart goes as well. So it is still super, super important to maintain the kidney protection. And then vessels and clots, I just sort of mentioned this briefly because I don't know if any of you all here have Raynaud's, but smoking is one of the things that I tell all of my patients. If you listen to anything I'm saying about your heart, stop smoking. That is doubly true of folks with lupus, that they can have uniquely reactive vasculature. Vasospasm is an entity that responds to smoking. I've had patients who've lost fingers from smoking and Raynaud's just because they didn't get enough blood flow. The fingers actually fell off. So clots are very common as well. Antiphospholipid syndrome, I think we're using APS now, I should have corrected that, is a clotting disorder that overlaps a lot and seen in a little under half of folks with lupus, and about a third over every 10 years from time of diagnosis, third of folks will have some kind of blood clot. So the reason you'll need to hear about that is you need to know what to look for with clots, what do you do about clots, and what does that mean? And then as far as these global things, what can we do? And right now, it's basically the same stuff we tell everybody else. Keep your weight healthy, don't smoke, keep up exercise, physically active. I tell people anything gets your breathing up, gets your heart rate up, counts as aerobic exercise. If it's gardening, walking, doesn't matter. But we want something that's working your heart a little bit. We do want you exercising. That's a big take-home point. It is okay to feel out of breath. That's fine. As long as you rest and feel better, that's where we want you. We also want you controlling your blood pressure. Super, super important. As we said, home blood pressure checks. We want every one of our patients has a home blood pressure cuff, an upper arm cuff. We don't have to check it every day, but a couple times a week, different times, just have a sense of where you're living at home. And we care a lot more these days about what your home blood pressure is than your in-office blood pressure, because we've learned that your in-office blood pressure is not very accurate. You're also not living at the hospital, so that doesn't really matter. Well, some of you may feel like you're living at the hospital, but ideally you are not. So big thing is stay on top of all that stuff, like you said, or like you'd expect. As far as medications, there is no formal recommendation for primary prevention aspirin and statins. So these are two medicines. Statins and aspirin are things that if I'm worried you have a risk of a stroke or a heart attack and you have not yet, if you've had one before, I want you on it, no question. If you have obviously have blockages, I want you on it, no question. But for any of you who have never had a heart attack or a stroke, but you are at risk of it, there's a question of, do I start you on a statin? Do I start you on an aspirin? And the global rule for both of those is it will protect your heart and brain. It will lower your stroke risk. It will lower your heart attack risk. It will also, the aspirin, slightly increase your bleeding risk. And the statin will very, very, very minimally increase some side effect risks. I'm happy to discuss with that further, but long and short, statins are not what's causing your muscle aches. If anybody tells you they are, it's 6 other things first, and then maybe the statins, but probably not. So they are both very, very reasonable to initiate. And I would probably say most of my patients over the age of 45, if they said, should I be on an aspirin or a statin if I have lupus, I would probably say yes, because you will get a benefit for your heart health. And if you don't have an obvious risk associated with taking the aspirin, a bleeding risk, issues like that, then I see it as a very benign, very low risk treatment. However, I say that with the caveat that we have no recommendations formally. All of the evidence we have, if you ask a general doctor, they'll plug your numbers into a formula, a calculator that does not include the fact that you have lupus. That data is not factored into any of our calculators. That was not factored into any of our studies. So I don't think those apply. I think we should treat differently in this setting. But you will have plenty of people who, if you go up and ask them, they'll say you don't qualify for that. And technically they would be correct because you are not in the data that was studied. I'm happy to discuss that further, but it's a complex decision is the point. And it's a fair thing to have a conversation about. I'm sure you all know this, but as best you can, we don't love high dose long-term steroids. I'm sure many people in this room have more thoughts about that than I do. And then anti-inflammatories in general, we don't like NSAIDs. I don't think they're as bad as some of my colleagues do. I think that an occasional dose of an anti-inflammatory or an ibuprofen is really not that big a deal for heart health. But we really don't have anything as far as evidence of directly treating autoinflammatory disease or lupus in the treatment of cardiac manifestations. There's a couple of really specific things I'll get into later where we do, but for the most part, we think controlling your lupus protects the heart. We have a little bit of evidence to suggest that. Theoretically, absolutely, but I can't speak specifically to if you get your numbers to this, it will be better. I can just say if you keep your lupus under control, it will probably be better for your heart health. And there's a little bit of evidence for some of the medicines. So this is the inflammation term part, the stuff that can be bad when it gets there. So cardiomyopathy literally just means heart muscle disease. This is, if you look up what can happen in lupus, you can get cardiomyopathy. That is just anything that has damaged the heart muscle. If anybody has diagnosed you with an actual cardiomyopathy, meaning they've said, yes, I believe you have that, you've earned yourself a cardiologist. That's basically all that means, is you need somebody who knows, is that a real condition or not? But people throw that word around a lot, and it doesn't necessarily mean anything other than that you need somebody to study it. And after that, it becomes, so this is just in here to say this is what my usual patients, what I talk to them about. I talk to them about cells getting sick. I talk to them about rhythm problems, things like that, heart getting from the normal heart here to this dilated sort of baggy heart on the side. That happens to anybody who develops a progressive cardiomyopathy, whether it's lupus or not. Fortunately, the treatment for all of that is the same. If you have any of those things, if you have a heart failure condition, a cardiomyopathy, you need a cardiologist, but the treatment's the same as everybody else. So I'm not even going to go further into that part. It's just people with lupus are at a little higher risk. This one's a little unique. So I don't know if you've heard the term pericarditis or myocarditis. COVID myocarditis was in the news a lot. That was a big deal. As we said, itis is just an inflammation. Myocarditis of the heart muscle itself, pericarditis of the sac that surrounds the heart, myopericarditis or perimyocarditis, depending on which one is predominant. They can overlap a lot. There's lots of complicated stuff about how we treat one or the other, but for your purposes, what I want you all to take away is it looks a lot like a heart attack. It is inflammation in the chest around the heart that feels to patients a lot like they're having a heart attack. Depending on which one you have, it can look on your EKG a lot like you're having a heart attack. It can look on your labs a lot like you're having a heart attack. And you really need an expert who knows, not necessarily an expert in cardiorheumatology, but a competent emergency department, cardiology department, et cetera, who, are familiar with sick patients to determine, because they would reasonably, I have seen people taken for treatment for a heart attack for one of these conditions when it turned out not to be. And the relevant part is the treatment for a heart attack. It's not nothing. We go in and do a procedure around the heart. It carries risks. And so the reason I'm telling you all about this is that I want you all to be aware that you can have something that looks for all the world like a heart attack, come in, feels like a heart attack. Some people in the room might think you're having a heart attack, and then somebody else comes in and says, no, that's not what it is. I'm not gonna chase this down. I'm not gonna take you to the lab. I'm not gonna do an invasive procedure on you. And that person might also be right. They might all be correct in what they're thinking. So it is complicated, and you have to both advocate for yourself when you don't feel well. If you know something's wrong with you and they're saying there's nothing wrong with you, then you need to advocate and say something is different here. That's okay. But also if they say, look, something's wrong, but it's not a heart attack, this doesn't need treatment, you also need to be ready to hear that as well. Because sometimes the treatment is more dangerous than letting the thing ride out. Most of these things are scary and unpleasant, but rarely dangerous, unlike the heart attacks, which are actually dangerous. These ones are usually just unpleasant. They can become dangerous. Here's why in my world we care about them. You may hear the term pericardial effusion. An effusion is a collection of fluid outside the heart. You always have a little bit of heart fluid there to help lubricate it. When you get more fluid, it starts to squish the heart. The same inflammation that when you get swollen joints, you get those big boggy swollen areas with extra fluid filling there. Same thing happens with inflammation around the heart, except when it's around the heart, instead of causing you pain there, it squishes the heart and keeps it from functioning. That is a true emergency. That is something that we will take you immediately to the ICU for, to drain it and get you there right away. So if somebody says you are having an emergency, I need to take you for this procedure right now, they may be correct. However, again, usually it's nothing. Almost always, they'll see it, it'll be fine. They'll say you've got an effusion there, it's not causing any troubles, I'm not worried. Those effusions occur in over 50% of people in some studies. If you just go around scanning people with lupus, you will find some degree of excess fluid there. But the actual rate of it involving the heart is only about 5 or 10%. So most of the time it's nothing, but once in a while if somebody says it's really something, you got to listen to them because it could be. And these are the specific things. If you hear the word tamponade, that's our word for scary pericardial effusion, where it's squishing the heart till it can't work. And then myocarditis and heart failure, that's where this is really affecting the heart directly, and it can cause immediate danger. And we may have to keep you in the ICU briefly while things calm down. Again, these are the rarer things, but then this is why it can occasionally be serious. But the treatment is basically supportive. We have good treatments. We get some anti-inflammatories on board, and almost everybody gets better. We just got to get you through it. These are, again, scary, not dangerous. I have this in here just to say, again, super complicated, lots of causes. I won't belabor the point, but poorly understood what causes this, well understood what we do about it at this point in the immediate management. As we said, overlaps in each of these, more complicated than worth going into. This is the specific therapies we mentioned. I won't belabor the point. Colchicine is our go-to. We love colchicine for pericarditis. It has just been approved for coronary disease as well, so lots of my patients are getting colchicine these days. Anakinra, rilonacept, and canakinumab are additional agents which are well studied. Our institution did a lot of that research, and the guy, Dr. Klein, who's a real leader in that field, believes very strongly that these will one day prove to sort of remove the colchicines and such. As of right now, there's still the therapies if you are refractory to initial treatment, and I will defer to folks who use them more than myself to say what their implications are. But those are the only sort of targeted medicines we do kind of have in the cardiorheumatology space. And again, it's a spectrum. I include this here just to say, if you keep getting pericarditis, it can eventually get scarred and have what we call constriction. Even that is treatable. We can remove the pericardium. But if you ever hear somebody starting to talk about constriction, that's when they're getting concerned about it the pericardial sac is getting too tight. It's getting dangerous, and we may have to do something more significant. And again, this is just recurrent treatments, backup options. I won't belabor that. I wanted to include this so you'll know what we see. So that's the inflammation stuff, basically. Inflammation, chest pain, looks like a heart attack, but often isn't. Valve issues in lupus. This is another thing you'll hear a lot about. Mitral prolapse is the most common one, the mitral valve. Aortic involvement as well is common. You have 4 valves in your heart. They're basically the doors, the close after blood goes in and then opens to let it into the next chamber. The aortic valve is the exit chamber from the heart. The mitral valve is the entrance chamber to the main chamber of the heart. So I just wanted to include this to show you all what we're looking at here. This big part in the middle is the left ventricle. That's the main chamber of the heart. This is the left atrium where blood goes from here down into the main chamber of the heart. And usually this red goes to that blue. This red, blue. That's normal. In. But every time this is coming back out. See this little jet going to the side here? That's what we call regurgitation. So this is all supposed to go up into the ventricle and not back out. And that about a third of that is going back out the wrong way. So every time your blood has to pump, a third of the blood is going in the wrong direction and has to be pumped out again the next time. This is when we start to worry about needing to do something about a valve in patients with lupus. And this happens largely for the same reason that other connective tissues issues happen in lupus, that these valves are made of connective tissues. I won't pretend to understand the histology underlying it, but there's an embryologic similarity from what I understand. It is why these connective tissues that make up the valves and the areas around them are also more prone to degeneration, patients with lupus. So this is the picture that we see when I say, okay, well, I'm worried that's not going the right direction. And this is a sort of graphic of it, of what we're looking at. That's that same mitral valve. And that prolapse, what that means is one of those little leafs is pushing out into the back chamber in a way that it shouldn't be. It should be just sort of nice and even on both sides. And you can see if that keeps happening, eventually those two sides won't close and it'll start opening up and flow will go in the wrong direction. The prolapse part where you get a little loosening, extremely common, about 60% 20% for prolapse, 60% for some kind of valve problem in lupus, which is quite high. But like everything else I've said, almost always mild. Usually just something you have to monitor. We care about it because we need to keep an eye out for if it becomes serious. But 5% of regular or non-lupus patients will have these things as well, versus 20%. It's not unheard of in the general population. And then this term vegetations, I'll talk a little bit about what that means. That basically means a bit of schmutz on the valve, and we don't know what it is. That happens in about 10% of people with lupus. In anybody without lupus, we get worried that that's an infection or that's something scary. In somebody with lupus, it's really, really hard to know what to do because you get a lot of little things there that look like it but aren't it. So again, we got to keep our eyes out. Oh, and then if you have antiphospholipid, it's also more common. So I'm putting this all on the clotting because the valves get clots on them anytime you have an irregularity. They get infections, they get clots, stuff sort of sticks to them, and then they fly off. And that's largely why we care about the valves. The valve failure itself is quite rare. Only about 1 in 20 folks will ever actually need a replacement. And these days, that's very safe procedure. If you do need it, get it done at a major center that does a lot of them. But it's a very safe procedure. The reason we really care about this is infective endocarditis. So this is an infection of the heart valve where you get a little bit of bacterial schmutz that sits on one of those curved leaflets. So the problem is when that leaflet starts to buckle or tear or anything's abnormal, that makes a little hinge where a bit of gunk can catch onto it. So it's very, very common. Anybody with an abnormal valve is more prone to developing infections of the heart valves. Other things that put you at risk, being immunocompromised, which means somebody who has lupus, somebody who's on treatment for lupus, having valve problems we mentioned, being prone to clotting, people who have skin wounds or skin breakdown, people who have dental infections, basically lots of stuff that people with lupus have puts them at risk for endocarditis. The symptoms, here's what you all really need to know about endocarditis. The classic symptoms, you just look sick. You look like you are very sick, you have fevers, you look like you have a bacteria in your bloodstream because you do. That's the main thing that somebody comes in with. And so if that ever happens with somebody with lupus, you know as well, if you're feeling for fever and you're not feeling well, you got to get checked out. And even if nothing's going on with your heart, they may need to look for a source of infection at the heart or from the heart. Stroke is the other big thing I want everybody here to be very aware of. We care about clots because those clots can fly off. Doesn't matter whether those clots are around an infection or they're around a messed up valve or anything like that. Infections can fly off too, and we care about where they land when they fly off. If they land in your brain, we call that a stroke. So it is very, very important for everybody here to know and recognize stroke symptoms, because anybody who's at risk of clotting can be at risk of developing a stroke. Anybody who's at risk of valve problems can get a stroke, and that's something where knowing the symptoms really is life-saving and getting care fast. So again, rare stuff, but stuff to be aware of. And then the other similar issues would be if the clots don't go to the brain, if they go to the belly, if they go to the hands, they go to the feet, things like that, they can cause similar issues. So sudden unexplained belly pain, if there is a finger that is suddenly dark and not feeling like it's getting blood flow, cold, painful, things like that, those can all be signs that a clot has gone somewhere in the body and needs to be checked out. And any of those can happen from either an infection or a clot on the valves. And this is just a brief nod to the FAST symptoms are always worth being aware of. These are not the only stroke symptoms, but yeah, facial drooping, one-sided weakness, speech difficulties, time is brain in these settings. So you really got to move fast if you're concerned. Again, common but important. This, you will hear this term, that's the only reason I put it, Lupus endocarditis. This is also a vegetation, quote unquote, on the heart valve. It's a bit of schmutz on the heart valve. Except it is not an infection. It occurs almost exclusively in people with lupus. A couple other conditions you'll also hear called murantic or non-bacterial thrombotic or NBTE. It looks a little different than the other one. It's not quite so much a schmutz of bacteria. It's more of what we call pannus or inflammation and clotting tissue around there. It's more common in folks with antiphospholipid and other clotting disorders. We think it's a kind of like a clot on the valve, but it's not a traditional clot because it doesn't look like, basically clots don't normally form on those valves. The treatment is confusing and complicated. It is, like I said, extremely common. Up to 10% of folks with lupus will have this. We don't think it's doing anything there. We don't think they're harmful most of the time. But the reason they're relevant is because they could be mistaken for infection. If you think that's an infective endocarditis and it's actually not, the treatment is often open heart surgery with valve replacement. So you want to be really sure that you are dealing with an expert team. I don't purport to be an expert imager, but we have expert imagers here who can distinguish between those two kinds of clot. And it's important that you be treated, if anybody's proposing heart valve procedures, you be treated at a place where they really are sure of what they're treating. And then it can very rarely cause stroke, just like we said, so they can fly off like the other things, that's still important, and they can cause the valve to degrade over time, so that's some of those 5% of people who need valve replacements. So if you start looking up lupus in the heart, what you'll get is pericarditis and Lupus endocarditis, and for most of you that will never be relevant, but that's why I mentioned these things, is they are real entities that are unique to lupus. And I also mention them because this is what we see on our echo. When I do an ultrasound of your heart, what I'll see is, this is again that main chamber. It's the same picture we saw before, but turned on its side now. So this is that main chamber, the left ventricle here. This is the left atrium that we saw before, had the blood going back into it incorrectly. And this is the outflow, the aortic valve. So the relevant part here is I'm looking at this aortic valve and it looks pretty normal to me. It looks pretty similar to this valve. It's moving nicely. It's opening, it's closing. I don't see any problem. And this is on the echo. When I just put an ultrasound probe in your chest, this is what I see. However, if we do a transesophageal echo, which I don't know if any of you have ever had, but that's where they take a camera, put it down your throat and look at the other side of the heart, because that gets much, much closer pictures to the heart. This is a real case, by the way. Then we see this, which we did not at all see. And I think all of you, not having folks who read ultrasounds a lot in the past, can probably tell there's something wrong here. That if you're trying to get blood out to the body past that, that's going to be a problem. And that's the entire blood flow to the body that has this big old schmutz there that at any point could fly off. And on our regular echo, I mean, I, for one, in retrospect, maybe I could convince myself that I need to look closer, but I certainly didn't see it there. So I tell you all this to say, somebody might say we need to do an ultrasound of the heart, and then they say it looks fine, but we need to do another one. You go, what the hell? We just did one of those. You want to put me to sleep and put a camera down my throat? Why are we going to do that? This is why. There's actually a different view that you get with the more invasive one, and that is relevant. So occasionally, these are the things where if somebody says you need this thing, you do in fact need to do that extra step. So all that, I know we got a little into the weeds at the end, but the point of that was to say that I really second the point made before that this is a team effort. It is confusing. It is a poorly understood disease. It is challenging for even those of us who do our best to stay on top of the literature, to stay on top of the best research. And It is the kind of thing where sometimes you will feel for all the world like you have a serious medical problem and folks will tell you, no, you're okay, and they'll be right. And sometimes you'll feel like you have a serious problem, they say you're okay, and they'll be wrong. And it's really hard to tell which is which, other than to warn you the fact that it's also hard for everybody else involved in it. And two very reasonable people could come to different conclusions about things like the aspirin or the statin. So that's why you really need this multidisciplinary team. Not every one of you needs a cardiologist. If you have been diagnosed with a heart problem specifically, thinking heart valve problem, a cardiomyopathy, if they say pulmonary hypertension, those specific terms like that, you should have at least seen a cardiologist, because you should follow these things to make sure none of this other stuff happens. But for the most part, most folks don't need a cardiologist. They need all the same heart health stuff everybody else needs. Don't smoke, keep a healthy weight, control your blood pressure, all that boring stuff. Eat natural and non-processed foods as best you can. But then when do you need an expert? Well, when any of those things we just mentioned starts coming up, those are things to prick up your ears and say, hey, I want to just make sure I'm being seen by somebody who is, on the cutting edge of this, because this stuff is complicated. And obviously happy to take any questions. Apologize if I ran a little over there. Thank y'all for your time. Oh, and special thanks to Dr. Heba Wasif, who invited me to speak here.
It's working now.
Oh,
Yeah.
sorry. Very last thing I forgot before the start. The question for the last person. We in our world we love Farxiga and Jardiance or dapagliflozin and empagliflozin, the SGLT2 inhibitors. I'll give my very brief spiel on those, which was that they were invented as diabetes drugs. They weren't great for that. By a coincidence of history, we studied them for heart danger. Found out that actually they are heart protective. We now consider them heart drugs that, by the way, also treat diabetes. You do not have to stop them if you have urinary infections. We can talk about that differently if people have concerns about it, but that's the most common thing. There's actually a piece in the Journal of Cardiac Failure telling people, please stopping your SGLT2 inhibitors. We really like those for the heart. So I'm happy to speak more to that if folks want. But
Sounds good. Thank you, Dr. Kelly. We appreciate all the information. Does anybody have any questions for Dr. Kelly? This is the area I find fascinating because, okay, here we go. We got one right over here.
Well, before I was diagnosed with lupus, they told me that I had it was a small drainage behind my heart.
okay.
So I still have it, but would that be a concern? I don't think I have any problems, but they still say it's there. I don't know the one and the other, do it coincide with one, or should they be looking at that? I don't even think I've mentioned it. Now, since you said that, I don't even think I mentioned it to the lupus doctor about it.
Totally fine. There. Thank you. It's a very fair question. That is exactly the kind of thing that I want y'all to be aware of, which is you should know if you have had, well, you probably had a pericardial effusion. They called it a drainage. I'm assuming that means a collection, because there's not a lot of way you can really have a drain there, but you probably had a pericardial effusion. So that's, we were saying in the slide, over 50% of patients with lupus, if you scan their hearts, you'll see a small pericardial effusion, and that's fine. It's worth knowing that you've had one in the past, because if you ever come in with sudden trouble breathing, sudden heart problems, and we're trying to think what's causing this, then it's important for your team to know, hey, I have lupus and I've had a pericardial effusion in the past. Chances are it'll never be anything. Almost certainly it'll never be an issue, but it's good to know, because if you ever do feel bad, that's the thing we want to be aware of.
I think that's great advice. I often go to new doctors and forget a lot of the things that we have on our lists, right, as lupus patients. So I always tell people, I usually keep like a little list and just kind of fold it and have it in my purse, because you get to the very end and you're like, oh, I forgot about something and it's really important. So very good advice. Any other questions for Dr. Kelly? Okay. Natalie?
This might be a little overcomplicated and out of scope. I have a pacemaker, so I've had routine heart issues over the years. When I had septic pneumonia, it affected my POTS really bad. So I always had high blood pressure. I was kind of abnormal in that sense. But now I have low blood pressure that alternates with high blood pressure. So it's like, how do you battle that treatment of like, okay, I'm really low in the morning, but now I'm super high in the evening?
Yeah, it's a really hard question. You're right. The questions about folks who have what we refer to as high adrenergic tone, meaning that their their sympathetic nervous system, the fight or flight system, is more responsive. It is more common in younger folks rather than older folks. Generally, young women are particularly prone to having these big swings in heart rates and blood pressure. And you're absolutely right. It's really hard to control. What I would say you do is there are medicines you can take that sort of tamp down that reaction. So metoprolol is the most common one, or carvedilol is a cousin of it. There are a medication class called beta blockers that are literally anti-adrenaline. They're adrenaline blockers, so they block some of that exaggerated response. Now the problem is on the other side, they do make you kind of tired, and so it's always a balance. I think the most important thing with the blood pressure is to think, what are we treating with this? So are we doing this because you feel bad? Are we doing this because you're in immediate danger? Or are we doing this because we don't want you to have a heart attack in 40 years? So when I worry about high blood pressure, almost always that's because I don't want you to have a heart attack in 40 years. It is very rare that your high blood pressure is immediately dangerous to you. It can happen, but you have to be above 180 on the top number, and usually you're above 200, and that's quite uncommon. Almost always when I care about high blood pressure, it's because I don't want you living there for 40 years because it's going to be bad for your heart. So to that end, it doesn't matter if you swing your blood pressure up to 170 for a few minutes. I mean, when you're exercising, that's a normal thing for your body to do, for example, as long as you feel okay. And when you get back to rest, it comes back down. So that's part of it, is don't worry about a transiently high blood pressure as long as you're feeling okay. That could be part of the body, or high heart rate as well. There's nothing inherently wrong with a high heart rate. It can feel unpleasant, and that can be a reason we try to control it, but none of those things are dangerous in and of themselves. On the other side of the spectrum, low blood pressure, we never worry about low blood pressure for heart health in general. For my purposes, lower is better in the long term, but in the short term, it can be dangerous. So like you said, when you had an infection, that's where I get really worried. And that's the part where if your blood pressure is ever low and you're not feeling well, that is now out of the heart health camp and into the let's make sure you are safe camp, and make sure you are not. And for anybody, I always say, if you ever pass out, don't know how you got there, you ever wake up on the floor, we're in the middle of a conversation, slump over, that is a don't pass go, don't collect $200, you are going to the hospital to get checked out. So that is when I care about low blood pressure. Short of that, low blood pressure is not dangerous. It can make you lightheaded, can make you not feel well. Don't be cooking, don't be driving when it happens. But other than that, it's not going to hurt you.
Okay. Any other questions for Dr. Kelly?
Is it typical for the cardiologist to work with the rheumatologist, or is it typical situation where a rheumatologist refers you to a cardiologist and then it's kind of separate?
Yeah, it's a fair question. And obviously, this is a developing model. Ideally, we would have everybody working very closely in collaboration. As you all know, that's not always true of the modern healthcare system. I would say that if you are somebody with predominantly lupus symptoms who has some heart involvement, then I would always let your rheumatologist or nephrologist or whoever's organ is primarily involved drive the show, because I don't have much data in my world about specifically the treatments and the monoclonal antibodies, the biologics, things like that I believe they impact my organ, but I don't have any data to justify it. So I'll just say, please control whatever part of the disease you can from your side. Now, if you have a primary heart problem, if you have heart failure, if you are hospitalized with heart problems repeatedly, things like that, that is the point where we start to say, look, I'm sorry, but my organ's the thing that's going to kill them. So I'm going to start feeling more strongly about what medications we use. And then maybe we talk down the line about the implications for, mobility and joint health. But until you are hospitalized with heart problems, you're very much still in the camp of the rheumatologists, and we're happy to help however we can.
Thank you. I think we have one last question here from the boss.
I was trying to hide. So, I was diagnosed with rheumatic fever for 19 years. Okay, is there an affiliation with the lupus and the heart and all this craziness?
Yeah. So rheumatic heart disease was the first time we understood any connection between autoimmune disease and the heart. Rheumatic heart disease is in fact an autoimmune disease. It's not the infection itself directly that does it. It is an entity that I cannot personally tell you the relationship between you having had that as a kid and you subsequently having lupus, but I'm sure there's somebody smarter in the world of immunology than me that could explain the connection for either why you were susceptible to rheumatic heart disease or how an early infection might have predisposed you to development of lupus. What I can say is, from the heart side of it, having had rheumatic fever as a kid puts you at risk of rheumatic heart disease in a way that has nothing to do with if you ever have lupus, and means that you always, that's one of those super important ones to know. If you ever do have heart problems, to make sure your doctor knows that you had rheumatic fever as a kid, because it's treated slightly differently then. It's quite rare these days for folks to have that. that shouldn't affect the rest of your lupus stuff. Basically, either you had rheumatic heart disease or you don't, and as long as you don't and it never affects your heart, you should be just fine. But yeah, you're probably right. There's probably something to the fact that you ended up with both of them. I wish I could give you maybe 100 years from now, or a better researcher than me might be able to explain to you what the link is.
Okay, thank you, Dr. Kelly. We really appreciate your time today. Okay, we're going to move on to our next speaker. Dr. Tony Fernandez completed his dermatology residency at the University of Miami, Florida, and a dermatopathology fellowship at the Cleveland Clinic. He currently practices both medical dermatology and dermatopathology and serves as director of medical and inpatient dermatology. Clinically, he specializes in the treatment of systemic autoimmune and inflammatory diseases with prominent cutaneous involvement. Dr. Fernandez will speak about lupus and the skin today.
Thank you, Adrienne. Good morning, everyone. As you can see, we're going to talk about lupus and the skin now. In most studies that characterize the clinical manifestations that occur in patients with lupus, the skin is found to be the second most common organ system involved with this disease. So, as you can imagine, if you have lupus, it is very likely that you're going to develop skin rashes, skin abnormalities at some point in the course of the disease. I think the first important point that I want to make is many of those skin rashes and abnormalities that occur are completely nonspecific. They do not represent lupus inflammation itself in the skin. And they are rashes and skin abnormalities that we can often see in patients who do not have lupus. And many of those are listed here. They're not important to memorize. It's just to underscore that many things that occur on your skin are not really a manifestation of lupus. With that being said, there certainly are rashes and skin lesions that we do believe are specific to lupus and that do represent lupus inflammation itself occurring in the skin. And that's what I want to focus on talking about today. And these can be classified as acute cutaneous lupus erythematosus, subacute cutaneous lupus erythematosus, and chronic cutaneous lupus erythematosus. Within each of those categories, there are certainly the most common types of skin lesions and rashes that will occur and that we see in our clinics. And some of them I have listed under this other category. There are much less common subtypes that we still see, but because of the time we have available today, we don't have the ability to cover every one of these entities. So we're just going to cover the most common skin rashes and skin lesions. And really what I want to do is go over the clinical manifestations so that you have some idea of what to look out for and recognize that may be occurring in your skin things that are specific to lupus. And then we'll broadly talk about how we treat these conditions. So let's start with acute cutaneous lupus erythematosus, or ACLE. ACLE occurs almost exclusively, if not exclusively, in patients who have systemic lupus erythematosus. So when we see acute lupus, we either know the patient already has systemic lupus erythematosus or has developed it. And there are two subtypes of acute lupus: localized acute lupus and generalized acute lupus. Far and away, the most common subtype is localized acute cutaneous lupus. And this typically presents as confluent or solid erythema or redness that's slightly raised or edematous on the malar eminences of the face. This is the so-called butterfly rash of systemic lupus erythematosus, arguably the most well-known skin manifestation of this disease. It's also important to note that patients do not always present with this solid area of redness on the cheek. Sometimes it can be papular or dots of red occurring on the face, but from a distance you can appreciate that it's in that butterfly distribution. And then generalized acute lupus is exactly what it sounds. It's not just localized to the face, but it's a more general eruption. This is much more uncommon. We do see it once in a while. And when patients present with this, it's not necessarily specific. It can resemble visually the types of rashes we see when patients have allergic reactions to medications, which are very common reactions, or when they develop a rash within the setting of a viral infection, or what we call a viral exanthem. Acute cutaneous lupus patients are typically very photosensitive. Excess UV light exposure is one of the key triggers to this reaction. And the reaction can be quite transient, meaning sometimes it's only present for a few days or it can last for a few weeks, but these rashes in acute lupus are typically not present for months, and they're definitely not chronic. And when they resolve, luckily, they resolve without scarring, so the skin will go back to looking like normal, which is great. And patients who have acute lupus generally have activation of systemic inflammation that is related to lupus. So it's also common that they present with other mucocutaneous findings of lupus, most commonly oral and or nasal ulcerations, which can be quite painful. Here are two patients with localized acute lupus. The patient on the left has the more classic confluent or solid areas of redness that are slightly raised over the malar eminences. And the patient on the right has a more papular presentation. You can see there are some areas that are starting to become solid, but certainly there are more sort of dots that are occurring on the skin, but definitely in that butterfly distribution. And again, when this resolves, it resolves without scarring. So this is that patient, probably a few months, this was years ago, I can't remember how many weeks or months it was when we took this second picture, but she has no scarring, which is great. The skin will go back to looking like normal. Here's a patient that we saw in the hospital years ago with acute lupus. So you can see she does have redness that's sort of solid in that butterfly distribution on her face. She also had some oral mucosal erosions. I know it's hard to see in this picture. So it's on the roof of her mouth, the hard palate. She had some painful erosions that we believed were due to active lupus inflammation. But from a distance, she has a much more generalized rash. And, you know, this is typically associated with significant systemic symptoms, and that's why she was in the hospital. It wasn't just for this rash alone. The second specific subtype of cutaneous lesions that can occur in lupus is subacute cutaneous lupus erythematosus, or SCLE. SCLE typically looks a little different on the skin than acute lupus. Patients present with scaly and annular or circular skin lesions, or they can present with skin lesions that very closely resemble the types of lesions we see in patients with psoriasis, which is probably a disease you've heard of, and a chronic immune-mediated skin disease that is much, much more common than lupus erythematosus. This is also a rash, luckily, that will resolve without scarring. So if we can make this go away, the skin will go back to looking like normal again. Patients also typically have prominent photosensitivity, and excess UV light exposure is, again, one of the key triggers to developing SCLE. And I think it's also important to note that that threshold for what is excess sun exposure is different in every individual. So I think those of you who are photosensitive, you kind of need to know your own body and know when you're at risk for getting too much UV exposure. Along the lines of photosensitivity, about 3/4 of patients who have SCLE when tested will be positive for an autoantibody called anti-SSA or anti-Rho, which is classically associated with photosensitivity. Many patients who develop SCLE will not have systemic lupus erythematosus, but it is common to find some mild evidence of systemic involvement. Most commonly, these patients will have arthralgias or joint pain, but sometimes they can have frank signs of arthritis in some of their joints. They can have abnormalities in their white blood cell counts being low, otherwise known as leukopenia. They often have a positive ANA. Luckily, when patients present with SCLE without known systemic lupus, there's a relatively low risk that they will ever progress to eventually develop SLE. The current estimates are somewhere around 10 to 15% of patients only will ever progress to develop SLE, which is great. And it's also important to note that many patients who develop SCLE do so because of a reaction to a medication they're taking. So when we diagnose a patient with SCLE, the first thing we do is look at their medication list, including over-the-counter vitamins and supplements, and try to determine when these were started and correlate it with the onset of their rash to see if we believe that there may be some correlation between those. There are some common medications that have been implicated in causing SCLE. There are many medications that have been reported to cause SCLE. So sometimes it's really hard to determine whether or not a medication is actually the cause of the eruption. Here are two patients who developed subacute cutaneous lupus erythematosus. If you look at the patient on the left, that's a man. If you focus on his sort of mid to lower back, I think you can appreciate the annular or circular nature of those lesions. If you look at the edge, they're much more red, they're raised, they're scaly, and then centrally there's pigment change, but not as much redness as at the rim. If you look at his upper back and neck, those are lesions that look more like psoriasis. They're bright red, solid red, they're raised, there's a sharp cutoff between the rash and normal skin, and there's thick overlying white scale. So the same patient can present with lesions that are psoriasis-like and annular or circular in nature. The patient on the right has just solid redness and rash in an area of photodistribution. So V-neck area, she was wearing a low-cut top. This was in Miami, where there was a lot of sun all the time, and that triggered her outbreak of SCLE. And this is just another patient with generalized SCLE that we saw here in Cleveland a few years ago. And again, I think you can appreciate, if you look closely at any individual lesion, that they're annular or circular in nature, with the edge being much more red, raised, and scaly than the center of those lesions. And then finally, the last specific subtype of cutaneous lupus is chronic cutaneous lupus erythematosus. Far and away, the most common lesion we see in that category is discoid lupus. So these are often considered just synonymous terms. Discoid lupus presents with raised lesions, or what we call plaques. They typically have areas where pigment is darker than the patient's normal skin, or hyperpigmentation, and then areas that are completely devoid of any pigment, porcelain white in nature. And the importance of chronic or discoid lupus compared to the other subtypes that we've been talking about is that these lesions heal with scarring. And once you scar, as of today, we have no way to reverse it. So in patients with significant discoid lupus erythematosus, there is risk for, over time, developing very significant physical deformity. So this is a subtype that we really try to keep under control, and depending on the severity of the disease, may want to be aggressive. Discoid lupus is often a condition that is localized to the skin. So most patients will develop this without underlying systemic lupus erythematosus. And like SCLE, if that is the case, then there is a very low risk that the patient will ever progress to develop systemic lupus erythematosus, even lower than with SCLE. However, it's well known that patients who have systemic lupus can develop discoid lesions. And the current estimates are somewhere around 8 to about 30% of patients with SLE will develop discoid lesions. Typically, the lesions of discoid lupus will occur from the neck and up, so essentially the head and neck. There are patients who certainly can develop skin lesions below the neck, and that we typically term as generalized discoid lupus erythematosus. If patients do develop lesions below the neck, there is research to support that those patients are at a little bit higher risk of progressing to SLE compared to patients who may present with skin lesions just from the neck and above. And it's also important to know that smoking, we believe, plays a very important role, not only in the development of discoid lupus lesions, but also in our ability to control it. There are many reports in the literature, and in my experience, where we have tried every medication we can think of, whether topical or systemic, to control discoid lupus in patients who smoke, and they do not work. And then the patient eventually stops smoking and the disease goes into remission. So the first thing we do when we diagnose discoid lupus is inquire about smoking. And if a patient smokes, we educate them about that association with the goal of hopefully encouraging them to quit smoking, which of course not only probably has benefits for discoid lupus, but has obvious benefits to their overall health. Here is a patient who has generalized discoid lupus erythematosus, so obviously she has lesions both on the head and neck and below the neck. And if you focus on the picture on the left of her back, and specifically just that lesion on her left lower back that's sort of football shaped or elliptical in nature. If you look closely at that, I think you can easily see that if you look at the rim of that skin lesion, it's dark, it's hyperpigmented compared to her normal skin. And then centrally, there's complete lack of pigment. It's white. That is all scar. So even if we can control the inflammation of lupus perfectly from this point on, those white areas are going to stay. We have no way to get rid of those for this patient on the back or on the face. You can also notice on her back, many of those skin lesions have red within them. That is active lupus inflammation. So that visually to us is a sign that her cutaneous disease is quite active. And because it's active, that means these skin lesions can get bigger, so the area of scarring can increase, and she can develop new discoid lesions in areas that currently look like normal skin. So this is a patient that we would say, boy, we need to do something to get this inflammation under control. Here are two patients who have discoid lupus involving the scalp, very common area where we see discoid lupus. And really what I want to point out here is you'll notice in those areas without pigment that there's also a complete lack of hair. So because of the scarring that occurs in the skin, the hair follicles are completely destroyed. And once this has become a scar and the hair follicles are destroyed, again, we have no way to get these back. So these patients will never, unfortunately, be able to grow hair in those areas again, you know, short of research somehow in the future allowing us to reimplant hair follicles. And this just highlights two patients to show you sort of the physical deformities that can occur over time. And because these lesions most commonly occur on the neck and the head, the physical deformities can have a significant psychological impact, socioeconomic impact on these patients' lives. So we want to prevent patients from ever getting here with discoid lupus, and the patient on the right also has scarring and even ulcers and erosions on the arms, which are quite painful. So you can tell that those specific categories of cutaneous lupus, the rashes look different. And when we do biopsies, we also see differences in the immune cells that are causing the inflammation. And this not only helps us explain what we see visually, but also knowing the patterns that occur under the microscope. If we do biopsies, it can help us distinguish between lupus and other causes of their rashes. So for acute lupus on the left, the immune cells, which are those dark red dots, are very high up in the skin. In subacute lupus, they're also pretty high up, but there is a more intense number of inflammatory cells. And then chronic or discoid lupus, you can see it's a really robust number of immune cells, and they're not only superficial, but they're deep. And because they're deep, the damage that is done to the skin in the deep layers, that's what causes the scarring. So it's that the difference of the inflammatory infiltrates that also accounts for what we see visually in the course of the disease that occurs in the skin. So how do we treat cutaneous lupus? Really for all subtypes, because many patients are photosensitive. The easiest and safest thing that we do is recommend that you protect yourself from the sun. And there are different ways to do that. Obviously, broad spectrum sunscreens are very important, but you can also avoid direct contact with the sunlight in a reasonable way. We want you to enjoy being outdoors and enjoy life. And that's why I say you also have to know what is your personal threshold of sun exposure before you think it's going to trigger your immune system in the skin to become active. And then also sun protective clothing. When cutaneous lupus is localized, when you have just a few lesions, we really want to try to stick with safe conservative medicines like topical medicines. And most commonly we use topical steroids, but also topical calcineurin inhibitors such as tacrolimus. and pimecrolimus. We often, when patients have more widespread disease or if they fail topical medicines, we'll use systemic treatments. And by and large, we use the same treatments to treat cutaneous lupus that we use to treat lupus inflammation in any other organ system. But certainly, far and away, the most common class of medications that we use and what is considered first-line systemic treatment are the antimalarials, which are hydroxychloroquine or Plaquenil and chloroquine. And the studies have suggested that hydroxychloroquine is far and away the most common of those two that we use. And studies have suggested that about half of patients with active cutaneous lupus will see improvement in their disease activity in the skin by their first follow-up visit about 3 to 4 months after they've initiated treatment. And there's also data to support that if you have lupus, but you do not have skin involvement and start Plaquenil, that it may protect you from ever developing cutaneous lupus. In one study, 5 years after patients started hydroxychloroquine, there was only a 5% chance that the patients would have skin damage compared to a cohort of patients with lupus who had not developed skin lesions yet and did not start hydroxychloroquine. At 5 years, about 25% of those patients had skin damage. So I think that's been a recurring theme, the value of anti-malarial medicines in lupus, and that's certainly true when it comes to skin involvement as well. We like the anti-malarials also because they have such a good safety profile compared to so many of the other systemic medicines that are used to treat cutaneous lupus and other manifestations. And so, at least for the skin, it's not uncommon for us that if a patient fails or has a reaction to the first anti-malarial agent that we prescribe them, whether it's hydroxychloroquine or chloroquine, that we may try switching them to the other one before we move on to more quote unquote aggressive systemic therapy. And there have been studies like this one that have shown that if you switch a patient from one anti-malarial to another because they failed the first one, it didn't control their skin disease, at least 50% of those patients will respond positively to the other one at 3 months. And even in this study, at a year out, still more than 40% of the patients had a positive response. And if you have a reaction to one anti-malarial agent, in this study, it showed that about 70% of those patients not only tolerated the other anti-malarial agent, but had a positive response to it. So this is something that we may do. And just to let you know that, just because you fail one anti-malarial agent or have a reaction to one does not mean that you're going to fail the next one or have a reaction to the next one. And if the second one works, again, we try this because the safety profile of these medications is so good compared to most of the other agents that we use. With all of that being said, we still have a huge unmet need in our ability to effectively and safely treat cutaneous lupus erythematosus. And luckily, this is a very exciting time in cutaneous lupus, and I'm sure Dr. Littlejohn will show you that it's an exciting time for lupus in general. There is a lot of research that is currently going on, and these are just clinical trials that are currently up and running or almost up and running, looking at novel medications for specifically cutaneous lupus erythematosus. And we're a site for the first study there from AstraZeneca and the study at the bottom from Pfizer. So we're excited to see if these are medications that are going to be more effective and safe for cutaneous lupus than what we currently use. The first study, AstraZeneca, is a medication called anifrolumab, or many of you may know it by Safnello. Maybe some of you are even taking it. So this was a medication that was approved for systemic lupus in 2021. I'm sure Dr. Littlejohn will tell you more about this. But almost immediately after this medication was approved to treat systemic lupus, reports began to surface describing patients with refractory cutaneous lupus within the setting of systemic lupus whose cutaneous disease essentially went into remission once they were started on anifrolumab. And this was the first study that came out, just 3 patients. There have been more and more studies that have come out. So this in particular is a study that we're very excited to be a part of and that we hope to see similar results as what other people have reported. And finally, I just want to leave you with some current research looking into really the cause of lupus on a cellular level and molecular level. Don't get caught up in this diagram. But traditionally, we've thought of a cell that circulates through the bloodstream called the plasmacytoid dendritic cell, or the PDC, as being the key cell that produces the inflammatory molecules of lupus, things called type 1 interferons. More recent research suggests that maybe it's not that cell. And in fact, that in this research, it was the most common cell in the skin, something called the keratinocyte, that they found to be the key producers of this type 1 interferon, not only in patients with systemic lupus, but patients who were at risk for lupus and who had not yet developed it. So there's a lot more research that needs to go into proving this, but if true, it may really change how we not only look at the skin, but how we approach treatment, not only for patients who have systemic lupus, but potentially interventions that we can think about in patients who we believe are at risk to try to prevent them from ever developing systemic lupus, with the skin maybe being something that we specifically target. So in summary, there's a lot of things that can occur on your skin in the setting of lupus. Many of them are nonspecific, but hopefully you've learned something about sort of the 3 specific categories of skin rashes and lesions that do occur in the setting of lupus. In terms of treatments, sun exposure and limiting your exposure to UV radiation is very important, especially if you know you're photosensitive. And then we do have numerous topical and systemic medications that we can offer to control cutaneous lupus, and there are many exciting emerging treatments in the pipeline right now. And finally, in terms of our understanding of how lupus actually occurs, it turns out that the skin may not just be a passive bystander that is attacked by lupus inflammation, but in fact may be a key to producing lupus in patients, and time will tell if that's the case. So with that, thank you for your attention. I'd be happy to try to answer any questions. And if there are any questions we don't get to, or you want more information about our studies, you can feel free to email me at the email address shown here.
Thank you, Dr. Fernandez. Does anybody have questions? Okay. Go ahead, Dr. Littlejohn.
Thank you, Tony. That was great. How good are we, and by we I mean dermatologists, at looking at skin and saying, oh yes, I'm just confident that it's, acute cutaneous lupus? And I ask this because I have a lot of patients who come with a red rash in the face or the chest, and I can't tell based on the history if this is rosacea or lupus or polymorphous light eruption. So is a biopsy truly needed? And, any thoughts on just looking and being able to tell just by sight?
Yeah, that's a great question. I think it's a patient-by-patient basis for me. So I think, despite the fact that all I've done, for 15 years plus is look at skin all day, every day, there are many patients who come in where I'm not sure if even if I know they have lupus, whether they have a history of skin-limited lupus or systemic lupus, really what I'm looking at. So I think sometimes it's clear, sometimes you get these textbook presentations, but even, for example, if a patient comes in and, I'm 99.9% sure it's subacute cutaneous lupus because it's photo-distributed, it's annular lesions, we'll typically do a biopsy because there is always that chance that we're being visually tricked by what we see. And, I didn't go into all the details, but I'm sure there are many different rashes that cutaneous lupus can mimic, or that can mimic cutaneous lupus. So I think, when we do biopsies for all of you, it's, even if we're pretty sure that we know what we're looking at, really the reason we do that is not because we want to cause you pain and put a stitch in you, but we want to be extra sure we know what we're dealing with. And I think that's important, whether we think you have skin-limited disease or systemic lupus. At the end of the day, whatever decisions we make about treatment or anything else we do, we want to feel as confident as possible that we're making the right one. So I think the short answer is, I think a lot of times I'm as unsure as you. And Yeah.
Thank you. Hallie?
First of all, I'm completely overwhelmed with all the information that I've gotten today. So thank you. I've been diagnosed with fibromyalgia and Sjogren's, but I have a negative ANA, but I have a bunch of lupus symptoms. I have been diagnosed with eczema, but how do I know I don't have skin lupus? And I have a breakout now, so if you want to look at me, you can tell me. But how do I know the difference? And if I'm always dismissed as, oh, you have eczema, how do I know to continue, like the other doctor said, to continue to advocate for myself and push forward?
So I think a reason why I wanted to show you all those pictures and really talk about those specific subtypes of lupus is there certainly is value and reproducibility in the patterns that we see visually. So the areas where lesions occur, the sort of the shapes of lesions, like those circular lesions of subacute lupus, the scarring of discoid lupus. So a lot of that can help us when we see very nonspecific rashes, feel confident that you do not have lupus, that in fact it is something else. But as we were talking about just now, where we really get our details is under the microscope. And the patterns of inflammation, the cell types that are in a piece of skin that we take from a rash can tell us a tremendous amount of information and be much more definitive in terms of distinguishing between lupus and some other inflammatory process that's occurring in the skin. So if you're frustrated, I've done this many, many times, and I'm sure I will many, many times in the future, even if I say it's not lupus, and a patient is frustrated and just has in the back of his or her mind that the rash they have may be lupus, I'll say, do you want to do a biopsy? We can get more information. It's invasive, but it's about the most minimally invasive procedure that's out there in medicine. And certainly we get way more detail than we can by just visually looking at your skin.
Thank you. Moving along here.
I just wanted to ask, what's the minimum SPF or sun protection that we should all be using?
We typically recommend SPF 30 as sort of the minimum threshold. And that's really even beyond lupus. We think that's the best. For lupus, certainly you should look for broad spectrum sunscreen. So you want to block both UVA and UVB sunlight. And beyond that, there are many different types of sunscreens. Usually what I recommend to patients is you just need to find one that feels comfortable enough on your skin and that you'll use, that you believe is effective for you. I know me personally, I don't like the way sunscreen feels on my skin, most of them. So I don't recommend specific brands. I think you want SPF at least 30, broad spectrum. Beyond that, you just got to find one that feels good enough that you'll actually use it.
Okay, thank you. Time for 2 more questions here real quick.
I have an issue. I came from Toledo, and we don't have summits and stuff like this here. And I'm scouring. I went all the way far as to Virginia, North Carolina, and stuff like that. And I'm kind of upset that we don't have because the young lady, I have the same thing she have, and they tell me that I have eczema and I have sores all in my mouth and stuff like that. And I'm a veteran, so I can go to 2 different extremes. But when I got diagnosed, the veteran told me that I gained weight and I was overweight and I needed to lose weight. And I didn't, so to that extreme, I didn't have lupus. I had to go on the outside. So I have to search high and low for people. We only have few. We have a few that will at the University of Toledo that will stay there to do the study. Then they do the study, then they'll leave, and then you don't have a doctor no more. So it's like I'm out there I'm hanging on a tightrope. So it's either I stay there, come here, or go to a city. Then I got to start all over. So I'm just it ain't even really a question, it's a statement, but I'm just, out there just is there a place that we can find some places where you can say, okay, here's something that's in this area to help to people that have lupus that can go and like find some places out that are nearby us?
You want me to take that one, Tony?
Yes, if you have something on your webpage.
Okay. I think that my recommendation to you and to any patient that's in that situation, if you are in a city where you do not feel you're having as much luck with that longevity of physicians, things like that, I would recommend going to a larger medical center. And unfortunately, it does take some travel for you. There are resources. We are available. We do have a nurse on staff at our office. You are welcome to call anytime. Her name is Rita. She's wonderful. And I encourage anybody at home to do the same. We have patient navigators across the state. We do have some up towards your area that can speak with you. So why don't you give our office a call any day, Monday through Friday, 8:30 to 5 o'clock. We're going to help you out, okay? Okay, you're welcome. One last question.
And I would say that we certainly understand the frustration, depending on where you live, how challenging it can be to go see providers that you have trust in. But I would say that if you go there, and of course, we hope you think the Cleveland Clinic is one of those places, and really do get the treatment and care that you're looking for, that will pay off in spades in terms of your everyday quality of life, even how often you have to go to follow-up appointments. So it's worthwhile, whether it is Cleveland Clinic or somewhere else.
Okay, I have a two-part question. When I first got diagnosed with lupus, they did a scalp biopsy, and it came back my ANA was positive, and they diagnosed me with discoid.
Mm-hmm.
Then, not too far down the line, they diagnosed me with the SLE. Secondly, alopecia, and it took a whole big patch out the front of my hair, and this was some years ago. So they sent me to a dermatologist, and at that time, I don't know if they still do that, he was giving me once a week 10 shots of steroid in my head until my hair came back. It never came back with the same texture, the thickness. It came back real thin. And I would like to know, first, how did that discoid turn over to SLE? And then, do they do that anymore? Because when he would do that, I wouldn't go to work. Because like I said, he would do me the 10 shots at one time.
So to answer your first question, how did the discoid lupus become SLE? It's likely just a manifestation. So luckily, most people, if you diagnose with discoid lupus and you have no systemic lupus that is found when working you up for that, there is a low chance that you will ever progress to systemic lupus. But 5 to 10% of patients will, and I think unfortunately you're in that 5 to 10%. You make up some of those numbers. Number two, do we use injections of steroids? Yes, absolutely. You would be surprised how many patients we have come in every day for various, it's all scalp. It's inflammatory conditions of the scalp, whether lupus or not, to get injections. And the reason we do that is because, number one, an injection is different than a topical medicine. You have sort of an upper layer of skin. And when you put a topical medicine on top, it has to penetrate all the way through that layer before it can ever start to do its job, which is to get inflammatory cells out of the skin. But when you stick a needle directly through it and then deposit the medicine, you've bypassed that. So you've put a very good concentration of medicine right where it can start to work and do its job. And still, although the injections can be painful, although somehow on the scalp, people just, they come in, we can't keep them out. They want to come in more than we want them to come in. It's still, again, everything's a benefit-risk ratio. It's much safer to give you a localized treatment than a systemic treatment that's going to circulate in your bloodstream and all of your organs are going to be exposed to it. So it comes in, it's always a risk-benefit ratio, and the patient plays a role too. So if we have patients who say this is too painful, then we'll move on to something else, but we do still use that strategy.
All right. Thank you, Dr. Fernandez. We appreciate your time today. Watch your step. Watch your step. Okay, thank you, everyone. I just want to encourage everybody to hang in there. We're running a little behind, but we do have lunch for our in-person attendees. And Dr. Littlejohn is here with some very, very exciting information about research and what's going on in the world of lupus. So I'd like to introduce Dr. Emily Littlejohn. She's a staff rheumatologist at the Cleveland Clinic and is co-director of the Lupus Clinic. She completed medical school at Western University College of Osteopathic Medicine of the Pacific. She also holds a Master's of Public Health in Epidemiology from Boston University. She completed her internal medicine residency at Loyola University Medical Center in Chicago and a rheumatology fellowship at the University of Michigan, where she developed an interest in working with lupus patients. Dr. Littlejohn will present us with updates on lupus and clinical research. Thank you.
Well, happy Lupus Awareness Month, everyone here. I know I'm the last one and the one keeping you from lunch, so I'll try to be brief and focus mostly on the second half of my talk, which I think is maybe more relevant. But what I'm going to do today is take you through the challenges of treating lupus. I probably don't need to tell this crowd, but we'll go through kind of the mechanisms and the science behind it. I'm going to review how far we've come, because there's really been a stalemate in terms of treatment options for lupus. And really, since 2020, we're in the lupus renaissance. We'll talk about some recently approved medications and then a preview of what's ongoing in terms of phase 2 and phase 3 trials, and then some hints and tips for management. So as everyone knows here, everyone's systemic lupus is different. I can't say that I have two patients who have the same lupus fingerprint, I like to say, or manifestations of lupus. So as you can see here on the outer circle, some patients have renal disease and musculoskeletal joint pain, and others have neuropsychiatric lupus with changes in their bloodstream. So everyone is very different, and some people are lucky enough to have isolated renal lupus versus, having all of these manifestations. And what we think is behind these different manifestations is the inner circle, which is the different types of immunological heterogeneity. And what I mean by that is there's lots of different mechanisms that can cause the different manifestations of lupus. There's probably a lot of overlap in that space, and what we're trying to do kind of this day and age is parse out what's from what and what manifestations are being driven by what from your immune system. So this is a very busy slide, and this is probably the culmination of, I would say, decades of research that have come to this being the mechanism of underlying lupus. And you'll see here there's about 6 or 7 different stages here, and I'm not going to go through all of them, but the point of this slide is to show you that we are at work to find different medicines that will work at different levels here. So I'm going to draw your attention to this area in the middle here where we see belimumab. And most of us know Benlysta or belimumab. That's a approved medication since 2011. And that here is working on the Bliss pathway. So we know the Bliss pathway kind of makes our B cells grow and mature and produce antibodies. And that's just one example of a drug that we've targeted to a known mechanism. And you can see here there's a few others in this diagram. It's complicated, as you can see. There are multiple mechanisms, and the takeaway here is that there's lots of targets for new drugs and lots of potential. So let's go through the approved drugs for lupus. The first one was quinine, which was described in 1894, which was really the precursor for hydroxychloroquine, which is the lupus life insurance medicine that we'll talk about in a second. Aspirin was also then approved. We moved through to the steroids, which all of you probably have been on or at least know about. And then finally in 1999, the FDA approved cyclophosphamide or Cytoxan, which is a very strong medicine used for nephrotic syndrome in lupus. More recently in 2011, we had Benlysta approved for systemic lupus, but not yet approved at that point for lupus in the kidney. So really from 2011 on, there was really not a lot going on. A lot of research was happening, but not a lot of big, large-scale phase 3 trials to then tell the FDA that we can approve more drugs. Finally, in 2020, we have what's called the lupus renaissance to many of us. And this is a time period where not only do we have new drugs, but 3 were approved pretty quickly for lupus. That is belimumab or Benlysta for lupus in the kidney, which Dr. Provenzano alluded to. Voclosporin, which is also a medicine for lupus nephritis, and anifrolumab, which is a wonderful medicine that Dr. Fernandez alluded to, which is for systemic lupus, but also very, very good for lupus in the skin, and one of the only medicines that works, I would say, after probably the first dose. So then we can see here all the manifestations of lupus, and I just put the new medicines that were recently approved to help with treatment. So Treatment of ulcers on the upper left here or mucocutaneous manifestations. We have now Benlysta and anifrolumab. You see on the bottom left for the kidneys, we have Benlysta and voclosporin. Upper right for the skin, we have Benlysta and anifrolumab. And then the bottom right for joints, which is a difficult manifestation to treat, joint pain and joint swelling. We can use both Benlysta and maybe anifrolumab. And this is in addition to all the other medicines that we've had with or without good results. We're not doing really well, I would say, in terms of treatment for some of these areas of the body, in particular, as Dr. Provenzano mentioned, the kidneys. So this is already outdated. This is an article from March of 2023. And this just outlines all of the medicines that are in different phases of drug development. And you can see here the outer area is phase 1 medicines. And phase 1 is really small scale trials looking for safety. And if something gets passed through phase 1, it goes to phase 2, where we not only confirm safety, but also look at doses. And then phase 3, which is the closest to being marketed, which are usually large scale, very patient-based clinical trials with many patients being enrolled at one time. So you have to kind of get through all these phases to then say, okay, let's now talk to the FDA and get this thing marketed. So this is already out of date as of a year ago. Things in the lupus space are just moving so quickly that we can't even produce enough information to kind of keep updated from the scientific world. And you'll see here there's some things that we'll talk about that are in the now phase 3 trial, but you'll see like rituximab has been tried. It's a medicine that we'll mention briefly, obizatuzumab and deucravacitinib, which is down here. So all this stuff is still very active. So these are the 3 medicines I want to talk about briefly. I don't want to overwhelm you with the data. And then we'll talk about CAR T therapy, which is really a new treatment in the lupus space. Very promising, very experimental at this point, but with some 2-year data that's very inspiring. So first of all, I think Dr. Fernandez mentioned this. Interferon is a pivotal part of the lupus pathway, and it's abundant in patients with lupus. How many of you here have had a lupus flare and you feel like you have the flu? Feverish, logy, sleepy. This is all from this mechanism or by which the protein interferon works. So interferon, when it's abundant in lupus patients and very active, people feel flu-like, and typically they feel like they're flaring. And like I mentioned, it's just a group of proteins that typically help fight infection, but in patients with lupus, it can cause the opposite effect. The amount of interferon is abnormal, and sometimes it can be found in the skin or in the kidney or in the blood, and it's usually the higher levels of it correlate with lupus activity. Just keep this in mind because a lot of these new drugs target interferon, and I think it's interesting that Dr. Fernandez also mentioned that interferon is heavily in the skin. This is just something that we don't talk about enough, but it's really a big driver for a lot of lupus symptoms. So anifrolumab, this is a specific medicine that's an antibody that blocks interferon doing its job in the body, which is what we want to do in patients with lupus. It's approved for systemic lupus already. It's a monthly infusion. So unfortunately, patients have to go into an infusion center, and it's 1 flat dose you get every 30 days. Side effects for this medicine include things like shingles and a small COVID signal in the old data that we saw. So usually before we start this medication, we like patients to have at least 1 shingles vaccine and also are up to date with their COVID vaccine. It's very good for lupus on the skin, very good for low blood counts, and probably very good for lupus in the joints. So it's been approved for systemic lupus, but the question is, what about for lupus nephritis? And there's some new data that we found from the TULIP-LN trial, which is really just an extension of, giving patients this medication who have lupus in the kidney. And what they found was when they gave this to patients who had lupus in the kidney who were already getting Cellcept or mycophenolate, which we consider standard of care, it improved not only the renal outcomes, meaning the kidney disease, but also non-renal outcomes. So other things like joints and hair loss and canker sores and rashes and things like that. So this is a very exciting study because this 2-year study shows acceptable long-term safety and tolerability in our patients, meaning patients did not do too poorly in terms of side effects. And they support ongoing investigation of this drug. So now this is going from a phase 2, moving into phase 3. So we should keep an eye out for this probably in the next few years in terms of approval for a new medicine for lupus in the kidney. Another medicine that's used for lupus in the kidney is something called obinutuzumab. This is very similar to rituximab, which is a medicine that maybe sounds familiar. We've already given it to some of our patients with lupus. But unfortunately, looking at trials with rituximab, it did not meet outcomes, meaning it didn't progress from phase 1 to phase 2 to phase 3.
So this medicine, obinutuzumab, we're hoping will have better outcomes and just better data to support its use in lupus. This is a busy slide. What's really just important here is to know that when we gave this medicine to standard of care, so patients who were on Cellcept who had lupus in the kidney, we found that not only did patients do well with increased renal responses, meaning their lupus in the kidney got better, but also the serologic profile of the lupus got better. So the lupus in the blood and the lupus in the kidney improved. There were some limitations of this study. We're not sure how long it will last, meaning we don't know, how many times we need to give it and for how long and, over how many years. But you can see that these patients really did improve. And the question is, can this progress, in phase 3 trials and then potentially be marketed? And this is just from our ACR conference from November of 2023. This is 2-year data, and basically that this medicine is going to be moving into a phase 3 trial as well. Deucravacitinib. So this is a medicine that's not necessarily for lupus in the kidney. And this is very exciting for me in particular because I have a challenging time treating patients with joint pain. When we think of lupus and joint pain, we think of hydroxychloroquine, we think of methotrexate, we think of Benlysta, and then we kind of have a drop off of options. And the last thing that we really want to do is put patients on long-term prednisone, even though it does really help with lupus in the joints. So this medicine is an oral tablet that you can take daily. And what they found here is that compared to placebo or compared to giving someone, just a regular pill that had nothing to help the lupus, there were significantly higher proportions of patients who met primary endpoints, meaning these endpoints of looking at the skin changes, the improvement of joint pain, and improvement of lupus in the blood, were all better at week 48. So, these results support the benefit of this medication, and I'm hoping this will then move into phase 3. There's not data quite yet to say that it will move into phase 3, but it's promising looking at the review of phase 2 data. So now I want to move into what's called CAR T therapy. Have any of you heard of CAR T therapy? So CAR T therapy is really exciting. The initial trial of patients using CAR T therapy in lupus came out of a German study. So in Germany, healthcare is pretty much socialized, and they have a lot of compassionate care programs, and they were able to find really sick patients with lupus and put them through this CAR T therapy. Now, what is CAR T therapy? Well, CAR T therapy is considered a living drug. So basically, we take your own cells out of you, we engineer them with this new technology using a virus, and then we kind of build them in the lab, and then we put them back inside of you. Now, that virus is prone to finding lupus in the blood and in the body and killing it. So it's really, we call it a living drug because it's using your own body, engineered and put back inside of you to then help with your lupus, your lupus in your blood. But this is not a new therapy. It's just a new therapy for lupus. We've been using this in the hematology or oncology or the cancer world for a very long time. We've been using it in lymphomas and types of leukemias and other blood disorders. So even though it seems experimental, it's really not. It's really tried and true in the oncology world. It's just new in our space for systemic lupus. So just to give you the step-by-step, because you will see that a lot of new CAR T trials will be popping up all over, particularly in Cleveland, but I think, all over the country. What we first do is we have you come in for a day and we take out a bunch of your blood, a bunch of the plasma. We then sift through it and only get the white cells. Then we send these white cells, particularly the T cells, to a specific lab. And they, like I said, they transfect it with a special kind of DNA virus, which then makes these cells lupus killers, for lack of a better term. We then grow the cells in the lab, and then we have you come into the hospital. We give you a little bit of chemotherapy, like cyclophosphamide or fludarabine, usually both. And after we give you these 3 doses of these chemotherapies, we then give you your cells back. And then we kind of just watch you. And these patients come into the hospital for about 10 days to 14 days, and you get the infusion on day 1, and then you just sit. And we kind of keep a close eye on you. We check your blood work. We make sure you're having no, side effects or adverse reactions. And so far, patients have actually done remarkably well. And when I say that, I mean drug-free remission. So this is the initial patients that I mentioned that were undergo CAR T in Germany. And this is, I think this is published in March of 2022. So this data is even old, but let me just walk you through who these patients were. So there were initially 5 patients total. If you look at the bottom here, 4 were female, one was a male, and they had about a decade worth of lupus.
all of them had been refractory to other medicines. So they had been given cyclophosphamide, Cytoxan, rituximab, Cellcept or mycophenolate, high doses of steroids typically, and also hydroxychloroquine. And all of them were refractory to all of those medicines. And when I say refractory, I mean despite these high dose medicines that are relatively toxic and very strong, they still had lupus either in the kidney and also systemically. This is just a profile of all the 5 patients that were enrolled. And really the only reason I put this up is to highlight that they were very, very sick. So you can see the ages here, 18 to 24. These patients, if you look at the organ involvement, they had skin, they had kidney, some of them had heart involvement. You can see some of them have lung involvement and also joint involvement. All of these had at least kidney involvement, plus or minus other things. And here are the results. You just want to focus on the bottom right here. So the nephritis ceased in all 5 patients, meaning there was no more lupus nephritis that we could find. The arthritis, their fatigue, and the fibrosis that we found in their heart or the lung all reversed and disappeared. The interferon level, which I mentioned, that's what the INF stands for, interferon, it was undetectable in every single patient, which is really amazing. And these patients were able to come off of all their medicines, even their Plaquenil or the hydroxychloroquine. So when this came out in 2022, it was like everyone went crazy for CAR T. You know, this was in Germany, like I said, as soon as the information really got dispersed amongst rheumatologists, a lot of pharmaceutical companies were really on the edge and trying really hard to get us to try to put up all these CAR T studies. But the question still is, you know, is this a really safe therapy? And I think the risks here are significant, but they are minimal. So there is a risk of something called cytokine release syndrome, which is a response to basically just getting any kind of immune cells given back to you, even if they're yours or somebody else's, but particularly your own. Your body recognizes it almost as foreign since it's been engineered at this point. And the concern would be you having a syndrome where your body kind of tries to attack these cells, and you know there'd be a lot of inflammation and havoc would ensue. What they have found, though, is that the risk in lupus is much lower than when it's been done in other oncology-related diseases, lymphoma or leukemia. Some of the limitations of this data is that there was only 5 patients, right? And they were young patients, so just by age, they were arguably a little bit healthier than someone who's had lupus for, 40 to 50 years. And also the initial paper only showed 600 days in terms of outcomes. And also, these patients were all Asian or Caucasian, which is really not the demographic that we see here in the United States of lupus patients, particularly here in Cleveland. So there was an update at the EULAR conference, which happened in the last, I think it was in February. So there are now 8 patients total that have come from this German study. And they have found that at 2 years, the second bullet here, all were in what was called DORIS remission. And DORIS remission is just a way to assess remission by your blood work, how you're feeling, how your physician feels that you're doing, something called a SLEDAI score, which is an activity measure. The median follow-up was 15 months. But like I said, even the longest patient, which was 2 years, seemed to still be in remission. I did hear a talk yesterday that said one of these patients actually, since this came out, had to be reinfused with CAR because they were relapsing, but everyone else apparently still is in drug-free remission. So this is promising. I think still 2 years in the span of someone having a lifetime of lupus is not a long enough time for me to say, oh, this is going to be the miracle drug and really give someone a whole new immune system. But I think it does put people at least into partial remission for at least a small amount of time. And I'm happy to say that we are doing this study here at the Cleveland Clinic. We have 2 CAR T studies that we'll be doing. One is enrolling now. Keep in mind that as much as we'd like to give everyone the experience of the CAR T trial, it is really for refractory patients, meaning you've been tried on at least 3 medicines for 3 months at a time, and your lupus is still not well under controlled. So now this is just the second half of my talk, which is really hints and tips for management of lupus. And this is just things that I've learned probably in the last 3 to 4 years from my own clinical experience, from hearing other lupus specialists or lupologists speak. So first I want to talk about hydroxychloroquine or Plaquenil. This is really the lupus life insurance medicine. And what I mean by that is every patient who's on this medicine, they, by nature of being compliant and being on this medicine, it does provide prolong life and improve survival in patients with lupus. But it is a lot more than that. And what I mean by more than that is it has a lot of other benefits. So It has been shown to reduce flares. It reduces organ damage. It can reduce the risk of thrombosis or blood clots. It triples the effect of mycophenolate mofetil. So those of you who are on CellCept or have lupus nephritis or potentially lupus in the kidney or the heart or the lung, it triples the effect of that medication, which is really incredible. It protects against cardiovascular disease. There's some data out of the Hopkins cohort. It shows that these patients are at less risk for MACE or coronary artery disease events, and also can reduce the cholesterol. It has anti-cancer effects, which is really incredible. You know, patients with lupus are unfortunately at an increased risk for GI cancers and also some gynecologic cancers, and being compliant on this medication can reduce that risk. Also reduces the risk of diabetes in patients with lupus, and like I mentioned before, it improves survival. So the new thing with hydroxychloroquine is checking blood levels. And the reason we do that is because this medication is weight-based. So anytime you gain or lose weight, you should tell your rheumatologist, because we adjust how we give this medication based on weight. We are now able to check levels in the blood here at the Cleveland Clinic, and there's a very particular range that we look for, but that range will change if you're either underdosed or overdosed, and we don't want either of those things to happen because, of course, the risk of retinal toxicity is high if you're overdosed. Other medications that are important to mention are proton pump inhibitors. So Dr. Fernandez mentioned that some medications can cause subacute cutaneous lupus or lupus on the skin. Proton pump inhibitors such as omeprazole, pantoprazole, they're usually given for GERD or for reflux, but we've been, more and more data has been coming out that maybe they're not a great idea in our patients with lupus. So the major cause of some cutaneous lupus issues, even in patients who don't already have lupus, is the use of a proton pump inhibitor such as omeprazole or pantoprazole. So there's a reason for just the general public to avoid these medications, but in patients with lupus specifically, you want to avoid them because it can kind of expedite the process of you getting lupus on your skin. We also know now that it can increase osteoporotic fractures, and there's a potential that it can worsen kidney disease. The last, I think, 2 years, there's been some data, not necessarily in lupus patients, but that these medications can also relate to dementia. We're still kind of on the fence if that's how strong that association is. But I just tell my lupus patients, listen, if you have terrible reflux and you're on this medications, that's fine, but it should not be a long-term option. It should be a short-term medication. So I'm going to talk about turmeric, which is a medicine that we used to tell all of our lupus patients, and actually all of my patients in rheumatology in general, that this was a really great anti-inflammatory, and this medicine is safe, and it's in curcumin, and it's in all these different spices and foods that we eat. But now we need to be a little bit more careful, because what we've come to find out is that there are some gallbladder obstructions or issues with gallbladder disease or stones that we've seen with this medication. It can also contribute to renal stones. It's been known to cause upset stomach, or what's called dyspepsia, worsen acid reflux, and cause some stomach ulcerations. And there are a lot of medication interactions. I just listed a few here, but patients who are on blood thinners or antidepressants, antibiotics, medications for allergies, chemo drugs such as tacrolimus, or tacrolimus used for lupus nephritis, or topical for skin. This supplement can interact with those. So you have to just be very careful before you go ahead and start taking these supplements over the counter. Actually, usually when I see patients, I say, are you taking any supplements? Because there are so many supplements now that we know are really not safe for patients in lupus. There's also a little bit of data that shows turmeric can worsen brain disease in lupus. And this is just done in animal models, but it's just worth mentioning here that, again, this is not just really a safe supplement to take. Cannabis, which includes CBD and THC. Now, this seemed to be kind of, especially being in the opioid belt that we are in Cleveland, we had initially thought this was going to be really great for all of our patients. Green pharmacies are popping up everywhere, and it's a great medicine to help with pain control, help the appetite. Unfortunately, there's been a little bit of data in models in animals that shows that this can worsen the proteinuria in lupus-prone mice. Now, we can't really extrapolate that to humans, but the point is mice that were given high doses of cannabinoids, they just had expedited lupus nephritis. So there's some concern that might be happening in humans. Same thing with vasculitis, which is actually not really new and not necessarily related to lupus in particular, but overconsumption of cannabis can cause a lot of local inflammation, but also inflammation of the blood vessels. The last thing that I'll talk about is low-dose naltrexone, because this is kind of the big new thing in pain management. So I think the bottom line is that in lupus in particular, there really are no studies. There's never been one large-scale study that we have taken a bunch of lupus patients and giving them LDN to see if it's an anti-inflammatory and along with a medicine for pain. Now, in studies in fibromyalgia, which we do see happen a lot in patients with lupus, it has been shown to be beneficial in both sense of well-being and also pain control. In rheumatoid arthritis, it was also associated with being able to come off of your disease-modifying medicines or DMARDs, which are typically chemotherapy drugs. There were no serious side effects that were detected. So really the bottom line is there probably is something more to the fact that it's causing an anti-inflammatory effect in addition to pain control, but I can't ever really recommend it straight out to my patients with lupus because I don't have any data to guide. So what I usually tell people is if you have tried it and it's helpful to you and it's really been life-changing in terms of quality of life, that's great. But just know it might not be a great long-term option because we're still accumulating data in rheumatologic conditions in this disease. That is all I have. Questions?
Okay, with that drug that you said that's a new drug, I take the hydroxychloroquine and the I can't ever say it, the methotrexate. I had to give myself the shots, and it's a horrible thing. I transferred both legs and stuff. When will this phase of the new drug be out? Because I don't like giving myself the shots. It makes me sick just to see a needle go in my leg.
I think you're referring to the deucravacitinib.
Yeah, I couldn't not pronounce.
That's okay.
How do you say it?
Deucravacitinib.
Okay, yes, ma'am.
So that medicine is not even completed phase 3 trials yet. Yeah, but I will say that class of medication is available. It's not particularly for lupus, but there are other cousins to that are available to use. If you're on methotrexate already, your rheumatologist could talk to you about these other options. Mm-hmm. Mm-hmm. Yep. I would talk to your rheumatologist about other options. That medicine can be given different ways, and there's other things for joint pain or for whatever indication you're taking it for that you could consider switching. Mm-hmm.
Thanks. Natalie, you had a question? So far I've pretty much failed on all of the therapies. So now for about a year and a half, I've been on Safnello, and we started tacrolimus. I'm noticing better lab results with the Safnello, but the fatigue has been really bad. It actually increased that. Like, are we noticing that with patients that that's an issue? Because I don't really know anybody else on Safnello to really have that outreach of support of like what people are going through with this drug. Because it's one of those, like, it has a different set of side effects each month. Like, every infusion is different. But the fatigue is consistent. It's like you get the week before and the week after the infusion is like extreme fatigue. And then you have 2 weeks in the middle where it's like our normal fatigue. So it's like, is there any way to try to combat that for like at least quality of life purposes?
I don't know your particular case, but I haven't heard a ton of patients who've had worsening fatigue or ongoing fatigue just on Safnello. And the nice thing about that medication is that you can add other things to it. So it's not one of these medicines that you have to be off of everything. It sounds like you're also on tacrolimus, but you can, add back things if you're still having some symptoms. So that would be my recommendation, whether that be a tablet form or, something else. But also we like to give that medicine 3 to 6 months. And I've noticed some patients who don't get it for just the skin, it takes longer for them to get relief.
Okay. I think, 2 more quick questions and then we're going to wrap up.
I wanted to ask you, I went on this lupus website, my lupus team, they give you a lot of articles and stuff. And they came out, they said they have a vitamin specifically for lupus facius. Have you ever heard of that? It's called Lupavita.
Suzanne might want to answer that. I have never heard of that, but I've heard it from
Did you hear
patients.
that?
Heard of it.
Oh, y'all heard
Yeah,
of
we know it.
I said I was going to
Yep. Okay.
Thank you. So yes, it came out a few years ago. A young man was observing his mother taking so many vitamins. So he threw them all in a potion and created it. He did ask us to push it out. My concern was, is this, and most vitamins aren't, is this approved by the FDA? Okay, so unless he had clinical specific scientific tests done, I never really passed it off to you folks, but it's been out there before COVID. A young man created it. I don't know. I think vitamins, you need to tell your doctor what you're taking. Okay.
Always check with your doctor.
Always check with your doctor, but it does exist. It's been around for years. Okay.
Thank you. One last question here.
For that CAR T therapy, so for me personally, it's more of just trying to see where exactly my medications are, where I can stay in remission. Because I'll be on medications and then out of nowhere, I'm out of remission. And we've tried different things. And if you are, I'm very interested in it, but I'm not anywhere. I'm down in Columbus. So, how would I find myself other than coming up here every now and then to try to see if I can get approved to do that therapy? How would someone go about on trying that?
So there's a clinical trial website that actually is very, yeah. Ohio State University is the issue is that not every CAR T study is the same. So pharmaceuticals put out different types of trials, and so it can be particularly for lupus in the kidney or lupus in the skin, or so you want to make sure that you would meet the criteria based on your type of lupus. But there, you can either Google it, or there is a clinical trial website where you can just put in CAR T lupus, and then it should show you all the available or the recruiting sites. And I think Laura said there is one at Ohio State. Is it for nephritis? Nephritis. Yeah.
Mm-hmm.
Do you have Brad Rovin by any chance, Dr. Rovin? No. Okay. Samir? We think there's opportunities for you in Columbus.
Yeah. So, Dr. Littlejohn, I have a question about the cartel. After sitting in on yesterday's high-tech version of it, okay, this isn't going to be a drug for every person with lupus, correct? And it's going to be extremely expensive, isn't it?
Yeah, that's an issue right now. So the two studies that we're doing, one is for lupus in the kidney and one is actually for other non-lupus. You can have lupus in the kidney for this other one, but you can meet the criteria based on, other manifestations. So the idea is to actually try to include as many people as we can, because right now the data, most people, I think all of them in this study that I showed you from Germany had lupus in the kidney. So the idea is, who is a good candidate for the study, and if we can get these people into trials, does it work as well as it does in other lupus nephritis, manifestations? So the first part of your question, it's probably not for everybody, and I don't know that I'd want it to be for everybody until they've really kind of failed some of our other medications, because it is expensive. And not only that, but there are other risks. So, I mentioned that the risk of the cytokine release syndrome, that can be so extreme that patients can have what's called neurotoxicity from cytokine release syndrome, meaning they can have comas or seizures and things like that. So we haven't seen that yet in lupus patients, but it's a possibility. So it's not without risks. But the flip is that the benefit so far has shown that these patients are all still in remission, which is unheard of in lupus trials. So it's promising, but yes, cost would be a huge thing. And like I said, right now it comes to the hospitalization for 2 weeks. I know companies are trying to look at ways to decrease that. Can they be in an infusion center only? Can they maybe just be in for 1 week? Can we have them to see a doctor every single day in the outpatient center? So we're working on that part of it, but that I think is a large part of the expense, is the hospitalization that goes with it.
All right. Thank you to Dr. Littlejohn. We appreciate it. Okay, everybody, this brings us to the conclusion of the Scaling the Lupus Summit today. Thank you all for joining us. I hope at home you hung with us and are still here. Just a few things in closing. For those of you that are in person, we are serving lunch after. Doctors, if you could just wait for me for one moment, I would appreciate it. Also, really important, in your folder, there's a demographic form and an evaluation form. Also at home, we are going to be sending that to you. So if you could all take a moment to fill that out and give it to our lovely fearless leader over there, we would really greatly appreciate it. It does help us secure future funding. I want to say thank you again to the Cleveland Clinic, to Beth for helping us arrange this day, to the doctors for speaking. And I also want to thank our wonderful our supporters and funders. We have, and if you haven't met them yet, they're still here hanging around in the back. I see Chad from Arinia, and we have Heather from Mallinckrodt. And so if you would take a moment to say hello to them. And also I want to thank GSK, the Ohio Commission on Minority Health, as well as the state of Ohio for helping us fund this program today. We really appreciate it. We're available Monday through Friday, 8:30 to 5 p.m. If you need anything, please give us a call. We have lupus patients in the office, myself, Suzanne, we have another one. So we've been through your battle. We understand what you're going through. We have a nurse, so please reach out to us. We're happy to help you in any way that we can. Thank you so much.